Well, I've had the nod, so thank you for coming to... Is it a blue dot at the moment? I think you're sitting within, so thanks for taking your time for this. I had an interesting, just earwigging somebody out the door saying, oh, shall I have pain now or shall I have pain later? And I think they were talking about which session they were going to, but still, thank you for taking your time here. My name's Will Gregory. I'm an advanced musculoskeletal practitioner, which means I trained as a physiotherapist, but then I've done a few extra bits since then, including my non-medical prescribing, so I do prescribe medications now, and part of my job is in Scleroderma physiotherapy. Another part is in pain management across rheumatology, where I work in a more advanced role. So I'm going to hopefully cover both of those angles, as well as some other bits and pieces I've picked up from my time, which is just over 10 years of working with people with scleroderma. So there's a little bit of research out there, but I think all of us who work in this field would say a lot of our information comes from you guys, the people who have the condition, things you've tried, things that have worked, things that haven't worked. And just to introduce that idea, and this is particularly for those that perhaps are accessing this talk online at a later date, I thought I'd put in some juicy slides to start off with, and you'll see why I'm talking through this. So just before I get to that, the areas we're going to look at is 4 different ways or 4 different angles, I thought, perhaps, of considering pain management with a long-term health condition. First one would be your medications, your drugs. The second one, obviously, my preference is physical modalities, but also thinking about talking therapies and mental strategies. And I know there's going to be a very good session this afternoon that 2 of my colleagues, Sarah and Oliver, are leading in the orange room, which will go into more depth on that. And finally, thinking about avoiding painful stimuli, things you can do to control the pain by that means. So going back to things that people tell me, just a little introduction. So perhaps my pain is fully controlled since I started using drug X, or it's fully controlled since I started treatment Y, or even it's fully controlled since I started strategy Z. What I should say is I have rarely heard those statements, and that is the nature of a complex chronic pain condition, that we do actually not have a one-size-fits-all pain control treatment that will work for everyone. And rather, what we're looking at is a combined approach. I'm glad to say I'm in pretty good company here because, oh, my second picture hasn't come. There should have been a picture there with the British cycling team at the Olympics. And if you are keen, you will have noticed that Professor Black also had a picture of a cyclist on her slide. So I am in very esteemed company. But thinking about managing pain in scleroderma and Raynaud's, there's no one set answer. There's not an obvious treatment for all, like I say. So therefore, we're left with this marginal gains type of approach. So can we get a 2% improvement from doing this, or a little 2% improvement from doing that? And I don't know how closely you follow the Olympics, but we did quite well. And certainly there's this talk of marginal gains around that, to the point where I believe some of the other countries were watching the British team, and one of the cycling chiefs, going back a few years, had said, our wheels are rounder than anybody else's. And you know, I think it is those little things that we can do that will make improvements. So going back to these 4 techniques, and before I push on to that, I should say, as we've alluded to, one size does not fit all. Some of you will have found a good strategy for pain control. Others of you will not. Some of you will come and see a health professional and we will say, aha, the best answer is this. And you'll go away and try it and say, actually, it did absolutely nothing for me. An example I have is heat treatment. So you have Raynaud's, it seems logical, try some kind of heat treatment on there to help. And it does help for 90% of people. I do have a few people who've come in over time and said, actually, I find cold really helps. And I have to say, well, that makes absolutely no sense. But if it works for you, that's fine. Try heat, see if it works better. But if it doesn't, then, you know, no 2 people are the same. So I thought we could take 3 or 4 minutes as a room full of people for you to share your experience, if you could, at this point. I have just put 1 or 2 word answers, please. So we may have some time later. If somebody wants to tell the room about their fantastic help they found, there is time to expand on that later if need be. But at this stage, I'm just going to try and fill this flip chart. If you could shout out things you have found that help you control your pain. And like I say, it could be medications, physical therapies, talking techniques. It could be pain avoidance. And I'll just try and scribble as many of those down before we go on to the slides. So is anybody brave enough to have a shout out? Painkillers. Lovely, thank you. Okay. Okay. Hot water bottle, lovely, thank you. Cold therapy, okay. Some gloves and socks, yeah, lovely. Ooh. Exercise, good. Meditation, yeah, great. Massage, yeah, great. Rest, yeah. Acupuncture, yeah. Tens, lovely. Reflexology, yeah. I think I've got a little bit of space up there, but if we're done, we fill the chart. What's that, sorry? Yes, okay. How am I going to word that? Asking for support, maybe? Yeah. I did think we'd fill the flip chart. Thank you very much. Well done. We could probably finish now because you've just given all the answers I was going to talk about, but let me give us a framework around that and have a think about what we do with those things. So medications-wise, there's 2 ways to think about this, and I don't really want to talk about your Scleroderma or your Raynaud medications because those are prescribed for the condition. But what I'd want to think about is what you take for your pain relief. So firstly, no matter what condition you have, it's important to have regular medication reviews because these things can tend to add up. And before you know where you are, you've got a prescription that goes on to 4 sheets of your pad, and you're not quite sure what any of them do, let alone how to pronounce them or whatever else. So having a professional review your medications at least once a year is wise to make sure there's nothing that could be interacting or is suboptimal. And it's surprising, running the MSK pain clinic that I run, how regularly we see people who aren't taking their medications as was prescribed through no fault of their own, or habits have changed, or the GP didn't quite prescribe it as had been suggested. So that's an important step to think about. So far as your pain relief goes, there's quite a lot of interest about the idea of a medication holiday, which isn't quite as exciting as it sounds, I'm afraid. But if you have been on a painkiller for a long time, we know they're only so effective for certain types of pain. And we're not recommending a medication holiday from your Scleroderma or Raynaud's medications, but certainly from a pain relief point of view, what's happened? You've probably had an occasion where you've been away and you've not managed to take your pain relief when you would do normally. How did it feel? You know, did you have a big aggravation of pain, or did you manage it okay? And therefore, perhaps with a medication holiday that's a more formal version of the accidental missed tablet, looking at 3 or 4 days without taking the tablet, does it make a difference? Is this drug still as good for you as it was 10 years ago when you started it? And carefully monitoring how your symptoms are around that. I must reiterate, this isn't your disease specific, this is the other medications there. Moving on to painkillers, some of you will be on different regimes and different levels of painkillers. We generally aim to get people on a 75% rule for their pain relief. So perhaps at some point they'll need 100%, the maximum we're allowed to prescribe, and that's fine to get through a particularly painful experience. But we want people to have an option to increase it during a pain flare, so that your regular pain relief might be on 3/4 of the standard maximum dose, and then we know if you're having a bad few weeks, you can just increase that and get the benefit from it. And it's a concern when people are on the maximum pain relief, because it means there isn't that variability to increase it during aggravation. And the final thing from your medications point of view is thinking about balancing your side effects compared to your benefits. We'll talk a little bit more about the specific medications, but a lot of the standard pain relief tablets come with associated drowsiness, fatigue, nausea, and other upset there. And living with scleroderma, people tend to be quite stoical and are used to downplaying these side effects, understandably perhaps, but thinking about what side effects are impacting upon you and therefore what's the best pain relief for you. I see people with variables of levels of pain, but even more variable levels of treatment. And you'll see somebody who says, look, I was on this drug, I'm not taking it anymore. Tramadol is the classic example, because when I take it, I'm just too drowsy and I can't function. Please don't talk to me about that drug, which is absolutely valid. And for some people, those side effects will be tolerable. For others, there'll be enough to say, look, I'm not taking that painkiller. I'd rather stay on a lower step. And talking about steps, this is where the ideas come from. This is the World Health Organization pain ladder. And this is a 30-year-old concept that's still used today. And it looks at controlling pain through a staged pattern. It was actually devised initially for cancer care, but is now used across the board for anybody in pain. Can you control the pain, firstly, at step 1, which is your paracetamol and non-steroidal drugs? If that's not working, if the pain's still there or it's increasing, we'd move somebody up to step 2, where we're looking at the opioid-based medications. And then again, if that's not hitting it, up to stage 3, where you've got the stronger opioid medications. That's the classic 3-step approach. And whilst we can step people up, also hopefully we can step people down as pain gets better controlled there. It's worth mentioning the adjuvants, the extra medications that aren't on the pathway. So once you're even on step 1, we'd be looking at non-classic painkillers. So there are medications such as amitriptyline, nortriptyline, gabapentin, pregabalin, also known as Lyrica, that work to control pain through different pathways that can be quite useful with a chronic pain condition. So this is the most complex slide I've got this morning. I'm not expecting you to memorize this in any way, but thinking about how we control pain, it is very tempting to look purely at tablets, how they work and where they work. And there is a whole different list of areas where you can have effect from your medications. What I wanted to pull out from this slide is that you can control pain from a non-tablet point of view, either here at the painful site or just in the spinal cord where it's initially processed, or you can control it up from the brain downwards. So you can control pain in an upwards fashion or in a downwards fashion to get to a non-medical, as well as through the drugs improvement. Thinking about the upwards, this is what's called the pain gate. And I don't know if the pain gate concept is familiar to many of you, but the idea is, and this has been around since the 70s, that the pain that's travelling up towards your brain to give you that pain sensation, it can be blocked by having an alternative sensation go through the gate. So this is you bang your elbow and you instantly want to rub it. And that's an inbuilt thing we all kind of do. And that rubbing sensation can be enough to stop the majority of the pain sensations travelling through. So it's the pain gate theory, the idea we can close the gate to the more difficult, painful sensations and replace it instead with rubbing, heat, cold, TENS machine, acupuncture, reflexology, whatever it may be in the acute phase when the pain is there. Immediate treatment can help via the pain gate. Rather confusingly, most of those treatments also work from a downwards fashion from the brain coming down as well. So thinking about ways we could close the pain gate without medication, and this is all on your flip chart paper, thank you very much. Relaxation techniques, I don't think we said specifically, but meditation, of course, is a classic form of that. Along that is breathing control as a relaxation technique, and we know that your breath is one of the few things that you can control when you want to, but most of the time we don't control. So it's only when you think about it you suddenly have to think, oh, I need to take a breath in, oh, I need to take a breath out. But the majority of the time it's controlled automatically. With breathing control techniques, by making you more aware of what you're doing with your breathing, that can allow the brain to better access its own inbuilt pain control techniques. We've said distraction, I think that made it onto the board, yeah, word for word, thank you very much. Guided imagery, another form of relaxation I've put there. Music made it onto the board, thank you. And also I put art therapy there as potential kind of pain gate mediating ways to control the symptoms there. So physical modalities, with my background as a physiotherapist, this is my passion, this is what I do every day in my clinic. And yeah, I'm glad the hot water bottle made it onto the list there. Also, you know, these heat patches are supposed to be quite well liked by some of the people I see, so you can just tear it off like a plaster and put it on the painful area. The heat is gradually released. That's the modern way of doing it. The old-fashioned way is the heat lamp that some of you may still have kicking around somewhere or another, or the wax bath, which traditionally is old-fashioned, but some of you may know that's been my last 3 years research project, is looking at the wax bath for hands and hand function in people with scleroderma. For that matter, it could be a hot sink with your marigolds on to warm up your hands to allow them to get benefit from heat. Electrical modalities, so yeah, TENS has made it onto there, and this is a transcutaneous electrical nerve stimulation. And the device is quite reasonably priced these days. You could pick one up for £15, £20 or so. And most NHS trusts will have a form of loan where you can borrow a machine and see what it does for you. I quite like the TENS because you can have the treatment during your painful activity. You can wear it whilst you're doing the gardening or whatever may be your main irritation. I've put an AcuPen there, but AcuPen is an electronic device that simulates the effective acupuncture that was mentioned. I've been doing acupuncture for people with scleroderma for about 5 years. I was a bit nervous initially, concerned about the skin changes and what effect that would have, but working with Professor Herrick, I'm fortunate to be an expert company, and she said, there's no concerns, we should still offer it. And it does work quite nicely to control local pain, decrease muscle spasm, and that's how we tend to use it in the NHS, as a muscle spasm control. It's almost like a deep massage. We know that regular stretching does maintain your joint movement, and certainly auto-assisted stretching, where you push the stretch a bit further, wherever it may be, has a better effect than just doing it by itself. So that extra push we know is helpful. Regular stretching, maintaining your range of movement and capabilities, should mean you have less pain with your day-to-day activities. And lastly, from a physiotherapy point of view, is cardiovascular exercise. And this level of research came out around the end of the last decade, so 2008, 2009. We know that if you are more physically fit cardiovascularly, you will report less side effects and less pain from your scleroderma. That doesn't mean you should all get up and run the London Marathon tomorrow or whatever it may be, but maximising your available fitness does have a good impact. I say available fitness, so it's knowing what's within your capabilities. listening to your body was up there. Thank you very much for whoever suggested that. And certainly if you did want to try and get a bit fitter, listening to your body is important. Interestingly, Professor Denton mentioned that the pulmonary artery hypertension, which can be a limitation to exercise capability in scleroderma, it can be had in isolation without the scleroderma. And in a physiotherapy world, the research around that shows you that whether your pulmonary artery hypertension is part of your scleroderma or not, you can still get fitter and fitter to the same rate. So the heart and lungs, although somewhat limited, still can improve and would improve at the same rate as somebody without the other scleroderma issues. So a really nice, positive piece of research there. So in preparing this talk, I thought I should look at these guidelines. And I know, again, Professor Denton has mentioned these in the earlier talk. And this is the BHPR guideline for scleroderma. And it's a fairly weighty document. It's around 10 pages of quite dense type, and it's a fantastic piece of work. What it hasn't got is an awful lot of advice that is non-pharmacological. It's mostly drugs and medications, but I just thought I'd pick up the non-drug components of it. So firstly, from a general point of view, it says that more research is needed, but most patients can expect to impact positively from the non-drug type treatments. Looking at them more specifically, it looks at moisturizing your skin, and I'm sure we could talk for hours about which is the best moisturizer out there, and I've had some wonderful things recommended to me by various people over the years, going from a moisturizing stick that the lady said, well, you must have this. You go and have this and show this to everyone you meet with scleroderma. I said, okay, maybe. And a chap I met at this conference a few years ago who worked on a farm, and he said the best moisturizer he had found was the one that he uses for his cow's udders. Not something, again, we can recommend on the NHS, but it's about finding the best thing that works to allow you to moisturize. We also know that the effect of moisturizing, the actual rubbing of the skin that creates heat and helps circulation, can be as good as the specific cream or gel you use. So it's the action as well as the product that's important. From musculoskeletal manifestation points of view, it looks at when you have overlaps. If you have scleroderma with some myositis or scleroderma with some inflammatory arthritis, then we'd treat it in the way we'd treat those other conditions. So that opens up a whole spectrum of different options treatment-wise. But again, there's nothing that's very clear to give you the best treatment. Going over to Arthritis Research UK, and I've lost their picture there as well for some reason, they look at, in the scleroderma leaflet that you probably will have seen at Diagnosis or since, it's a red-backed A5 thing that should have a picture there. It probably will have if you go online. It looks at the non-drug type treatments and talks about exercise as being one of the best things you can do to keep on top of your scleroderma, keeping your skin flexible, reducing tightening, and keeping your blood flowing freely. So that's nice that that's out there nationally. It talks about complementary medicine, and there is a whole field there of potential options to control your pain. The only one that's been studied in detail, actually, from their assessment is the wax paraffin baths, the heat from those. Outside of that, the research is very thin, and it leaves us unable to recommend a particular complementary therapy. And again, we're looking at the actual effects of the treatment in combination with the response you have to going for the treatment, the ability to feel you're doing something for yourself, the positive response you get from that. And that makes the research quite difficult. Diet-wise, there's a bit of talk about the healthy diet helping skin ulcers, but also being aware of digestive problems there. It talks a little bit about supports, aids and gadgets. I've not quite made it over to the SRUK shop on site here yet, but there should be a good range of supports, aids and gadgets there, or certainly information about them. And for some people, it's the ability to use these supports, aids and gadgets that allows them to function. I had a lady in last week whose hand function was very limited. When she's wearing her splint, which was newly supplied, a new version, a tighter fit, she had a lot more function. And whilst I don't like people wearing splints too regularly or for too long a period, it worked fantastically for her. So it's, again, worth thinking about how regularly you need to have a review of what aids and appliances you tend to use. Oh, yes, that's Arthritis Research UK. Sorry, if we had the leaflet there, that would have been there. And their website's well worth a look for a more broader arthritis information source. The last thing they talk about is dealing with stress. And this is something I think that is in all of their leaflets of a chronic condition. Once you're diagnosed with a chronic condition, as Professor Black said earlier, it can impact on your work capabilities, and with that, your kind of self-perception as well. We know from people with Raynaud's, stress levels can affect a Raynaud's attack. So it's very easy to say, avoid stress, but a lot harder for you to do that in your day-to-day life. But thinking of ways of controlling that. And that leads quite nicely into the third kind of pain control option, which is your talking therapies. I spent some time searching around Scleroderma talking therapies, and if you type it into Google, you may spend some time, but there's not a lot of hits there. Probably one of the lead researchers was a lady from Canada who did her dissertation around this area. And she said, one of her summaries was, even if I cannot control my scleroderma, I can control how I feel about it. And that's that ability to think about how your feelings affect your thoughts, which affects your actions. With that, relaxation techniques, cognitive behavioural therapy, are both highly recommended on the NHS for these kind of problems, but there are other forms of talking therapies that are out there and are available. It's not us saying your problems are in your mind, you need to deal with it. It's just looking at different strategies to control pain, and having those techniques on hand during a painful aggravation can be very useful. Within that, I thought I should put sleep improvements as well. I don't know how many of you can say you have the perfect 6 to 8 hours uninterrupted sleep every night, but it is a problem as part of many chronic conditions. And again, we know the depth of sleep you have and the quality of sleep you have can impact on your ability to heal and to control pain through that method. The final cornerstone, thinking about avoiding pain. So this is perhaps just sensible precautions that a lot of you will have picked up already. So we know the effects of cold will very much aggravate your Raynaud's. I'm going to tell a story that I've told quite regularly, and I'm glad to say I bumped into the lady whose story this is, and she gave me permission to tell this again. She's at the conference today, but this lady was a very keen athlete before the Scleroderma and Raynaud's started, and she wanted to keep fit no matter what through the condition. So she'd go to the gym most mornings, but the gym was not very well heated. So she'd get there and it would be freezing cold and a Raynaud's attack would ensue. So she tells the story of arriving at the gym in maybe 3 or 4 jumpers and a woolly hat and gloves and all the rest of it, and she'd be on the treadmill, and as she gradually progressed on the treadmill, one and then another and then another and another layer would come off, and it's what she had to do. People gave her funny looks, but it's what she had to do to avoid the pain associated with that activity. Somebody said listening to your body, and what have I written there? Yes, okay, and kind of not ignoring your symptoms there. And part of that is thinking about pacing or monitoring your activity levels. In other chronic pain conditions, we give out pedometers for our patients to wear, and we ask them to monitor what they're doing. We've been doing this for kind of 5 or 6 years, but I should say, suddenly people are coming in and saying, oh, I've got my wearable technology thing, and things have changed, and now patients come to us with their data. And it can be quite interesting to look at what your physical capabilities are like on a day-by-day, week-by-week basis, and is there an impact of certain things you're doing? And that implies kind of the pacing activity. We see a number of people who give us their graph, and they're quite active Monday, Tuesday, Wednesday, Thursday, Friday at work. Saturday, Sunday is a complete and utter write-off. They do very little. And we have to say, you're not pacing your week correctly. You know, this is your weekend. You need to get a bit more from it. So thinking about how you pace your activities is an important way to control your pain within that. We've had this, thank you very much, whoever volunteered this, so prioritising or delegating. And a very big challenge with your scleroderma is being able to say to somebody, look, I'm not going to do this, you need to do this for me. And kind of it's a bit of a pride thing potentially, but having that capability to have those people around you who will hopefully ask you before you have to tell them, but if not, then to be able to tell people, look, I'd rather you did this for me so I could do this. and being able to delegate through there, but also prioritising. Are there certain activities that you do on a weekly basis that don't really need to be done? We had a lady in one of our groups a few years ago who was vacuuming her house 4 times a day because she was very concerned about the dog hairs everywhere. And we had to say, do you really need to vacuum 4 times? It was a very delicate conversation, but thinking about, are there things you're doing that could be dropped? Is it a priority for you? And finally, with avoiding pain, thinking about activity modification or aids. We've talked about the splints on the lady I described, I saw last week. But are there ways you can change your day-to-day activities that make it more easy for you to do it? Activity modification looks at potentially, a workplace assessment or a day-to-day assessment of what you do in your house, how things are set up, and thinking about making them as simple as possible. And aids-wise, well, it could be the walking stick, the support, or whatever else, or potentially aids to allow you to do activities more easily. There's a whole load of kitchen devices that, again, I think they may be reflected in the SRUK leaflet. If not, you can look through, and there's adaptive cutlery and special handled scissors, etc., and so on, and things to allow you to use the equipment you'd like to use, but without aggravating your pain specifically with that. So I think this managing pain topic was something I was given in response to feedback from previous conferences, and it's something that comes up in our in-house meetings that we run once a year for Scleroderma. Thinking about the feedback they get from their pain management is something that's mentioned quite regularly, and it's a broad topic, and as I probably said, and perhaps the takeaway highlight is there's lots of things in this room that you're already doing. Thinking about marginal gains, it could be you're doing 6 of those, but you're not doing number 7 or number 8. It doesn't mean it's necessarily a prescription that will sort things for you, but it's worth looking at the broader scope of what other options do I have to better control my symptoms. I've heard a round of applause from next door, which implies we've reached that point. I think the timing schedules have gone a bit haywire at this stage. So I'll just summarise, and then at that point, if anybody wants to kind of further talk through these issues, we'll perhaps do that until we get kicked out or asked to move on. So thank you very much for your attention this morning, and particularly for helping me fill up that flip chart so effectively.